Hello, everyone. Welcome to another live stream event. My name is Melissa Favela, and I am the community educator for Southern Caregiver Resource Center. And I'd like to welcome you to today's presentation. Feel free to get comfortable, grab a pen, a notepad. That way, if you'd like to take notes, you have everything handy. Otherwise, this live stream will be available to watch on demand starting after this live stream ends. So let's go ahead and go to today's first slide for today's topic, the role of the caregiver in diabetes and dementia. And if we go into the previous slide where we have our learning objectives, we will be talking about the statistics related to diabetes and dementia. We will get hopefully a better understanding of what diabetes is, if this is new to you, or if you have a recent diagnosis, or your care receiver has a recent diagnosis. We'll go through an overview of what diabetes is. We'll discuss the relationship between diabetes and dementia, some of the considerations when we are caregiving and we have diabetes, and when we are caring for someone who has diabetes. Next slide, please. Now, as always, we'd like to start off with some statistics. Diabetes is considered an epidemic in the country, and you can find these statistics and most of this information through the American Diabetes Association, as well as the statistics that the county gets on almost an annual basis. But it is estimated that approximately 38 million people are living with diabetes in the country, which is about 10% of the population. Approximately 3.5 million adults in California have been diagnosed with diabetes, and it is estimated that about 180,000 adults are diagnosed with diabetes each year. And in 2021, in the county of San Diego, about 10% of adults were living with a diabetes diagnosis. Now, this goes hand in hand with the national number of adults living with diabetes. So as you can see, it is very relevant that we talk about this topic today, because we are in line with the national statistics when it comes to diabetes. Next slide, please. Now, what is diabetes? These are just some simple points that I want to highlight. Diabetes is a chronic condition. What does that mean? It means that once it is diagnosed, that condition is there for life. However, this doesn't mean that diabetes cannot be well managed. It can actually be very well managed, to the point where some people say they don't longer have diabetes, although this is because they usually take very, very good care of themselves. They follow recommendations, they make a lot of changes. However, it is something that is considered to be a chronic condition, therefore a diagnosis that is without throughout the rest of our lives. Now, diabetes is considered present in the body when there is reduced or no insulin production by the pancreas. And if this is a little confusing, no worries. We will be talking about this in detail in the upcoming slides. It is also increased blood glucose levels, or blood sugar levels, as sometimes we also hear it in the community. And this term is what it really defines our understanding of diabetes. However, we cannot forget about the role that the pancreas and the insulin has in this condition. And the very last point I want to highlight is that diabetes does require professional diagnosis. So this is not something that you can just think that you have or think that you might have and start self-medicating. You do need to go to a medical professional, to your primary care physician, and ask to see if you do have diabetes, and they'll conduct the necessary tests, which we will also be talking about today. But these are 4 main points that I did want to highlight before getting into the specifics. Next slide, please. Now, how is diabetes diagnosed? Well, as I mentioned, it is diagnosed through a medical professional. It could be our primary care physician, or if we have a, uh, a specialist of some kind, they can also do the test necessary. A blood test is required to diagnose diabetes. And the test that will usually make this diagnosis is called glycosylated hemoglobin, or the HbA1c, or most commonly known as the A1C test. Now, as you can see here in the slide, it is a percentage. It's giving us a percentage. Now, normal blood glucose levels are below 5.6%. Prediabetes is considered to be between 5.7 and 6.5%, and diabetes is diagnosed above 6.5%. Now, what do these percentages mean? Basically, what the A1C test is measuring is the amount of glucose cells stuck to our red blood cells in the last 2 to 3 months from the day that we got that blood test. So it is not giving us our blood levels or our glucose levels in our blood for the day of. It is actually giving us an average of the blood glucose levels that we've had for the past 2 to 3 months. Because we are receiving an average, that's why we are seeing a percentage here. Now, for those of you who maybe are a little bit more acquainted with diabetes and maybe you've checked your blood glucose levels with a glucometer, you'll notice that the numbers are different. They're larger, we don't have a percent in there, and that's because you're just testing the blood glucose of that moment. But again, the hemoglobin test, the glycosylated hemoglobin test, or the A1C test, it's actually measuring our average blood glucose levels that we've had in the past 2 to 3 months. And this is usually the diagnosis that the doctors utilize when they're looking for our if we have normal blood glucose levels, prediabetes levels, or if we have a diabetes diagnosis. Next slide, please. Now, there are types of diabetes, and we'll focus on type 1 and type 2 today, but mostly type 2. Type 1 is when there is no insulin production from the pancreas. Type 2, there's a couple of things happening, but basically we do have insulin resistance from our cells in the body. And we may also have reduced insulin production. And again, if this is a little bit confusing to you, no worries. We will go into this, into explaining type 1 and type 2 in detail. But I do want to highlight here that sometimes there are misconceptions or there isn't a good understanding of diabetes, or maybe there's some misinformation. But I do want to say that diabetes type 1 does not turn into type 2 or vice versa. They are different types of diabetes. So type 1 stays type 1, type 2 stays type 2, and we'll talk about what's going on in the body with these different types of diabetes. Next slide, please. Now, as you can see here, we have pathways. We have a pathway that says type 1 diabetes, type 2, and no diabetes. So what we are going to do here is go through each one and explain what is going on in our body in very simplified terms, or as simplified as we can for today. I do want to mention that if you ever have questions regarding these types of diabetes or diabetes in general, please talk to your primary care provider. Now, as you can see here, in type 1 diabetes, we have a few things happening. With type 2, we have other things happening. But let's start with the pathway all the way to the right where it says no diabetes. So we're going to imagine that we have a person who takes a bite out of an apple, let's say. So we take a bite, we chew, and those chewed pieces of the apple go into the stomach. in the stomach, they're broken apart more and more. Now, as those pieces of apple are in the stomach sends a signal to the pancreas to start making a hormone called insulin. And so the pancreas starts producing insulin while the stomach is reducing that apple into smaller parts. So the carbohydrates that the apple contains, once they cross into our bloodstream to be absorbed, to be utilized, they turned into glucose. And so that glucose is now in our bloodstream. So what happens here? Let's say we ate that apple because we're going to go on a walk. And so what is happening in our body is that because we need energy from the glucose in, let's say, our muscle cells, because we're going for a walk, then for that glucose to be used, it needs to be paired up with the insulin. And so insulin and glucose pair up, and then they are able to go into the muscle cells, and that's where the glucose gets turned into energy for our muscle cells. And so again, we are simplifying a lot of things, but this is for a body that does not have a diagnosis of either type 1 or type 2 diabetes, meaning that in theory, it is working as well as it should. Now, for type 2 diabetes, let's say we have a person who has that diagnosis. Same thing, they take a bite out of an apple, they chew, those pieces of apple land into the stomach where it gets broken down into smaller pieces. The stomach signals the pancreas to produce insulin. But as you can see here, we already have something going on. We can see in the image, which is the middle image, where there are about six cells of glucose, or molecules of glucose, sorry, and only 3 molecules of insulin, of the hormone insulin. And so if we go on a walk, we still need energy from that glucose. But if we only have half of the insulin needed to move the glucose into the muscle cells, then that means that half of the glucose that was produced, roughly here in this example, stays in our blood because there isn't enough insulin to move it into those muscle cells. And so that's why if, let's say, then we have a banana and then we have a meal and we have more and more food that produces glucose, but we're not producing enough insulin, then that glucose that cannot get absorbed into our cells just stays in our blood. And that's why our blood glucose keeps going up and up and up. And, a lot of the times that's why we need medication. Now, for type 1 diabetes, which is the pathway on the very left, we have the same example. That person with type 1 diabetes bites into an apple, the apple lands in the stomach signals the pancreas, and then we see something that's happening here. The pancreas cannot produce insulin. So no insulin is produced whatsoever. That doesn't mean that the carbs from the apple don't get turned into glucose once they're in our blood. They do. But what happens here? Then the glucose cannot be used as energy because there is no insulin to move it into our muscle cells. So a lot of times, and actually with type 1 is all of the times, that people need to inject themselves with insulin so that when they inject themselves with insulin, then that injected insulin can move the glucose into the muscle cells or any cells to be used as energy. So that's why type 1 diabetes is very closely associated with insulin injections. Now, again, in very summarized, I hope you get a better understanding of what's going on in the body when we talk about type 1, type 2 diabetes, or no diabetes present. Now, in the next slide, we're going to go down even smaller onto the cellular level. So we will check or see what's happening cellularly in our body when we talk about type 1, type 2, and no diabetes. Next slide, please. So as we see here, the first image is of a body that does not have diabetes. So we see the pink part is a part of the intestine, and the yellow part, like elongated yellow part, that's the pancreas. And all the way to the right, we see a very basic cell structure. And so what happens, the pancreas produces the insulin then binds to an insulin receptor in the cell, and then the glucose is able to go into the cell to be used as energy. But what happens here in type 1 diabetes? That is the middle part. Because the pancreas does not produce any insulin, then the glucose cannot go into the cell because there is no insulin to bind into that insulin receptor, and that glucose cannot go into the cell. Then for type 2 diabetes, we do have insulin production in the pancreas, maybe not enough, but then also what we might have is that for some reason, the insulin is not binding to that insulin receptor in the cells. Therefore, the glucose cannot go into the cell to be used as energy. That's why a lot of times we hear that diabetes type 2 is also called insulin resistance, right? I have type 2 or I have insulin resistance. And this is because the receptors in the cell become resistant to the insulin. So we could have two things happening with type 2 again. One is that there is not enough insulin production, and or that the cells are not communicating with the insulin, therefore the glucose is not able to go into the cell. So again, very just a general summary of what's going on in our body. If you still have questions related to this specifically, if you have diabetes or you're caring for someone who does have diabetes, it would be a very good idea to really understand what is going on in your body or in their body. So make sure that you talk to a primary care provider, a nurse practitioner, a dietitian, so that they can explain in detail what is going on. And as you get a better understanding of what this condition is, what is going on in the body, you'll better understand the recommendations when it comes to nutrition or medication management or monitoring on a day-to-day basis. So the better we know our bodies, the easier it is to take care of ourselves as much as possible. Next slide, please. Now, when it comes to diabetes, we do have risk factors, right, that can lead us to this condition. However, we have risk factors that we can control, so controllable, and we have risk factors that we cannot control. Let's start with the shorter list, which is the uncontrollable risk factors. They are age and genetics. We cannot change our age and we cannot change our genetics, right? Those things are with us even before birth. So it is important to understand that we cannot reverse our age, we cannot alter our age, and our genetics are part of us. And so those are uncontrollable. Now, thankfully, we do have a larger list. Those are the controllable risk factors. Now, some of these you might think, well, they're not very controllable, but we want to make sure that we say why we consider them controllable. The first one that you see there is prediabetes. Prediabetes is something that is there to let us know that if we do not make changes in our lifestyle, that prediabetes will turn into diabetes. So if we ever have a diagnosis of prediabetes, it is not there to scare you. It is there because it is a controllable risk factor. We're going to try to see what we can do, what are the recommendations from the professionals so that that prediabetes does not turn into diabetes. Then other controllable risk factors are other chronic diseases. Now, it doesn't mean that we are not going to have other chronic diseases. It just means that, same as with diabetes, we can understand them and we can take the best care of ourselves as best as we can so that we can manage those other chronic conditions as well as possible. Then we have tobacco and alcohol use. We know there's extensive knowledge and research that both tobacco and alcohol are not good for our overall health or our health in general. And so if there is tobacco use happening, reduce or cease using tobacco. If there is alcohol use, reduce or cease consuming alcohol. And again, that is considered a controllable risk factor. Gestational diabetes. This is the type of diabetes that can happen to people who are pregnant. And so we say that it's controllable because same thing, if we ever get a diagnosis of gestational diabetes, it is very important for the health of the person who is pregnant and for the health of the baby to manage it as well as possible during pregnancy. And after birth, taking care of the person who was pregnant, taking care of yourselves as best as possible so that that gestational diabetes doesn't turn into diabetes. Also, having a sedentary lifestyle, we can choose to move a little more, even if we have limitations, right? We may have mobility limitations, we may have limitations related to a health condition. You can always check in with your primary care provider or physical therapist and occupational therapist to see what are appropriate movements that you can do on a regular basis to be a little bit less sedentary. Weight gain. So it's not just about the number in the scale when it comes to weight gain, is what is going on to really get us to that number. So it's not just about making sure that our weight is as low as possible, not at all. We want to eat so that our body has nutrients, right? And so if we do gain weight, but maybe it is muscle weight because we've been working out a lot, that's okay, right? But we want to look at our weight not just in terms of number, but in quality of food, right? So if you ever have questions about what weight you're supposed to have or anything related to weight, it is a pretty good idea to schedule an appointment with a nutritionist or a dietitian so that they can do a very individualized assessment. And of course, the last one is an unbalanced diet. So that goes along with weight gain, right? If we are consuming foods that are not nutritious, that are giving us empty calories, well, then that is something that can definitely put us at risk for a diabetes diagnosis or other health conditions. And it is controllable, right? We might be able to make small changes that will lead to bigger results in the future. And we'll talk about that in the upcoming slides as well. Next slide, please. Now, complications. We used to focus a lot on the complications related to diabetes because we thought that this scare tactic would work and help people make changes. But right now, I want to talk about complications, not to scare you, but really to inform you, right? If these complications worry you, or if you have more questions, again, check in with your health providers. But these are here simply to inform that complications are a reality of chronic conditions. And when it comes to diabetes, these are the complications associated with it. One of the complications is cardiovascular disease. Usually when we have a diabetes diagnosis, we also want to make sure that we are managing not just our blood glucose levels, but also our cholesterol levels, our blood pressure levels, because everything's related to your cardiovascular system. So if one thing is off, let's say our blood glucose levels are off, then we are more likely to have issues with our cholesterol, meaning higher cholesterol, and our blood pressure, meaning higher blood pressure. So it is a good idea to not only manage our blood glucose levels, but also our blood pressure levels and our cholesterol levels. We can also have complications related to our kidneys, so causing chronic kidney disease. This is because the higher the blood glucose levels, the more our kidneys strain to really filter out that extra glucose from our body. So if this is happening for a really long time, we're not making any changes, our kidneys will eventually become tired, right? They'll stop working as they should, and that leads to chronic kidney disease. And that can in turn lead for individuals to need dialysis, which is also something that's considered a complication, and it is long-term. We can also have vision problems, and this is because our eyes are highly vascularized. And so if our blood glucose levels are high and high and high all the time, then we are more prone to having vision problems. We can also experience neuropathy, which is when our extremities, our hands and our feet start feeling kind of like a burning sensation, pins and needles. And this is because our nerve endings from our extremities, because of the high blood glucose levels, start becoming damaged, and it can be very painful. And again, it is a complication, so it doesn't mean that anybody who has diabetes will experience this, but it's just more possible to experience this. We can also have skin complications, which is, for example, having drier skin, or if we have a cut in any part of our body, but let's say, as we see here in the image in our feet, that cut can have a longer repair time. It just takes more time for it to close up. And so if it takes more time for it to close up, then we have a higher possibility of it becoming infected, right? So that's those skin complications can also become other types of complications. We can also have oral complications. This is very common and maybe a little bit less known, that people who have uncontrollable or unmanaged blood glucose levels have a drier mouth. They have a higher prevalence of gingivitis. They can have issues with their teeth, right? Their teeth can start becoming loose because the teeth have all these nerves going into them, right? And so those become damaged, then we start having more and more oral complications. So it is very important that if you have diabetes, that you also go to your dentist and to those appointments. Then we also have a risk of diabetic ketoacidosis. And this is usually more prevalent with type 1 diabetes. It's when we are not managing our blood glucose levels and they're very high. We're not taking our medication as needed. And so what happens is that the cells cannot use glucose for energy. And even though we have really high blood glucose levels, they're not going into the cells, right? And so the body has to break other things down to use as energy, and that leads to ketoacidosis in the blood. Basically, our blood starts changing, and this usually takes people to the ER, and we can identify it when people have like a fruity breath. And usually, again, this means that we have to go to the ER. People can lose consciousness, and it can even lead to a diabetic coma. And then at the last, in the last point, we have stroke, which is very much related to cardiovascular disease. Next slide, please. Now, we have two main ways of monitoring our blood glucose levels. Traditionally, there is the glucometer. The glucometer is the very classic, tip of your finger prick with a tiny needle, and then you put that drop of blood into a little strip, and it tells you what your blood glucose levels are in that moment. That is something that people still use, of course, but it's slowly transitioning into the continuous glucose monitor. Basically, what this is a little monitor that has a tiny needle, and you stick it to your arm, and it's continually measuring your blood glucose levels, whether it be to a different device or even to an app on your phone. And this continuous glucose monitor is excellent because it's not just giving you your blood glucose levels for when you do a pinprick in your finger, but all the time. And so this makes it much easier for your primary care provider or your specialist to look at your levels throughout the day through a certain period of time and do a better job at managing medications or suggesting changes, right? And so we are seeing a higher use of glucose, of continuous glucose monitor. And so again, if you have any questions, make sure that you ask your provider about these options. Next slide, please. Now, there are times when a person who has diabetes can have higher than normal blood glucose levels or lower. And so when we are talking about higher, it's what we call the hyperglycemia. We can have some signs and symptoms for it. Of course, it'll be high blood glucose. Some people can also identify it if they do a urine test. They can also find it there. But if we don't have a glucose monitor or we can't do a urine test, then we can figure out if we are experiencing hyperglycemia, if we are urinating too frequently, if we're very thirsty. And unfortunately, this is what can lead to diabetic ketoacidosis. So it is always good that if you have diabetes, to have a blood glucose monitor with you. If you're not feeling too well, you can always check your blood glucose levels that way. So that is for hyperglycemia, so high blood glucose levels. Next slide, please. Now we're talking about lower than normal blood glucose levels, and that's what we call hypoglycemia. And this is when the levels fall below 70. And usually we have more symptoms than the high blood glucose. So we may feel like our hands are shaky, we're nervous or anxious. Some people say that they're hangry, right? That's the feeling of nervousness, anxiousness, confusion, rapid heartbeat, being irritable, all these things. And so what you can do to quickly manage hypoglycemia is apply the 15-15 rule. So 15 grams of fast-acting carbs, so orange juice, right, candy, things like that. Then wait 15 minutes. Check your blood glucose levels again. If they're still below 70, then we have to repeat the 15-15 rule. Ideally, we wouldn't have hyperglycemia or hypoglycemia. We would be managing our blood glucose levels well enough that we wouldn't have these extremes happening, although it is always good to know what to do in case of. So make sure that you talk to your provider for specific recommendations when it comes to your case or the case of the person that you're caring for. Next slide, please. For medication, I am not going to go into detail when it comes to medication because it is something that is very personalized to each individual. I do want to highlight, though, that there are two main types of medications for diabetes management. We have oral medication and injectables. Again, there are many types of oral, many types of injectables. So it is something that the doctor will recommend. They may not recommend medication if we have a type 2 diabetes, but it's very well managed. They may simply want to monitor and tell the patient to continue, let's say, leading the lifestyle that they're leading, right? Maybe they're active, they're eating well, they don't need medication. But let's say maybe the doctor does say, you know what, we're going to start with oral medication, see how that works for you. If it's type 2, if it's type 1, again, we will need the insulin injections. But sometimes with type 2 diabetes, there is a mix of both oral and injectables. And sometimes that's why it's the mix up. Do I have type 1 diabetes? Do I have type 2 diabetes? Or type 2 turns into type 1, right? But it's not that it's changing. It's simply that sometimes the medication can also include injectables for type 2 diabetes and not just type 1. But again, this is something that is very specific to each individual, and we will not go into recommendations. So if you do have any questions, make sure to talk to your provider. Next slide, please. Now, this nutritional management image that you see here comes from the American Diabetes Association, which has an amazing toolbox for diabetes management, of course. But this is the very basic of nutritional management when it comes to diabetes. They recommend that in each meal, half of your plate is non-starchy vegetables. Then a quarter of your plate will be your protein foods, and a quarter of your plate will be your carbohydrate containing foods. Now, if you're not familiar with which vegetables are starchy or non-starchy, or which protein foods are recommended, all of those things, you can, and I would recommend to check out the American Diabetes Association website for more details, or talk to your provider or schedule an appointment with a nutritionist or dietitian. Next slide, please. Now, I want to highlight here in this slide the importance of understanding and using reading the nutrition fact label as a tool to helping us manage not just our blood glucose levels, but really understanding what we're consuming and being that informed consumer. Right now, there are lots of products that come with packaging that it's attractive for not just kids, but also adults. But we want to know what is in that product. What are the nutrients that I am consuming when I consume that product? So this is a very simplified way of looking through the nutrition fact label. However, I would recommend to practice. Of course, there are apps that already do this for you, and that's fair and good. We don't have a lot of time to be at the grocery store necessarily, but it is a good idea to at least feel comfortable going through the nutrition fact label in case you do need to watch out for specific nutrients, specifically for your health or the health that you are, for those that you're responsible for. So let's start with the very first thing, is understanding that the nutrition fact label is giving us the servings per container and the serving size. In this case, it says right here that the serving size is half a cup and that there are 8 servings in this specific container of this specific product. Now, this is going to look different for all products, but what I really want to highlight here is that the rest of the information from calories and on, or calories and below, they are just referencing that half cup, that serving size. They are not referencing the whole container. So for example, if you're looking at the calories in this case, it says 230 calories. That just means that that one serving, meaning half a cup, has 230 calories. If you want to know how many calories are in the whole container, because maybe you are planning on consuming the whole container, then you multiply the 230 calories times 8. Okay? But again, this just gives you an idea that starting from calories and under, all the information under calories is just referencing to that one serving size, so half a cup in this case. Now, that is the first step. Something else that I want to highlight here is the percent daily value. The percent daily value tells you how much of a nutrient in a serving of food contributes to a daily diet based on a diet that is 2,000 calories. To make this even a little more simple, we use the 5 and 20% rule. 5% or less of a nutrient means that that serving size or this product is low in that nutrient. 20% or higher means that it's high in that nutrient. Now, careful here, because I'm not saying that 5% is or less is good and 20% or higher is bad. We're just saying 5% or less is low, 20% or higher is high, right? And we're not attributing good or bad because there are no good or bad foods. They're simply foods that we want to consume more of and foods that maybe we want to consume less of, depending on our specific needs. So if you see here, for example, we have total fat, 8 grams, but if we look at the percent daily value, that's 10%. So in this case, the total fat isn't necessarily high or low, and so we get to be the judges of, is this something that I want to consume? Or for example, if we go down to where it says dietary fiber, it says 4 grams, it's 14%. Same thing, right? For fiber, maybe in this case, we do want to consume as much fiber as we want. So we want it to be closer to 20% as we can. So in this case, if it's 14%, then, that's pretty good. If I am specifically looking for an item that is very high in fiber, then maybe I do want to check out another product and see if I can find something that instead of being 14% per serving, it's actually 20% or more, right? And so again, this is just a rule to help you simplify the reading of the nutrition fact label. As you can see here, we have total fat highlighted, but I'm not going to go into that. But I do want to talk about the total carbohydrates and what we consider carbohydrates in the nutrition fact label. So we do have a total carbohydrate content there of 37 grams, and this is something that people who have diabetes do need to pay special attention to. Then we have fiber, and usually fiber is very helpful for us because it helps better manage our blood glucose levels. But then we have the total sugars, and then underneath that, we have added sugars. This line of added sugars was included just a few years ago. But basically what added sugars are those extra sugars that are added to the product. They are not naturally part of that product. They are added for flavor or for whatever other reason. But if you see here then in this product for that serving size, which is half a cup, we have 10 grams of added sugars, which is 20%. Then maybe for someone who is managing their blood glucose levels, 10 grams of added sugars or 20% is actually pretty high, right? So maybe it'd be a good idea to see if I can find a similar product that has less added sugars, or better yet, no added sugars. So this is just a very quick example of how we can use the nutrition fact label to better help us understand what we are purchasing, what we are consuming, and how we can apply it to our well-being. Next slide, please. Now, physical activity is always important. We saw in the risk factors that being less sedentary was something that we can manage. So making sure that we are being as physically active as possible. These are some very general recommendations. And again, you can always talk to your provider if you have any questions. At least 150 minutes of physical activity per week. Now we're suggesting 150 to 300 minutes a week, but let's say resistance exercises 2 to 3 times per week, flexibility 2 to 3 times per week, and again, just being more active, walking every day if possible. Next slide, please. Now, if you are a caregiver and you have diabetes, it is important to take the time you need to take care of your own health and not just the health of the person that you care for. If you are not in good health, you will not have the energy to take care of someone else. So what can you do to take care of your glucose levels by being a caregiver? Well, you can be informed, right? I've been saying throughout this presentation, make sure that you talk to your doctor. There are programs that are called DSMES programs, which stands for Diabetes, Self-Management, Education, and Support. And these are programs that are supported by the American Diabetes Association that go into each step of helping you manage your diabetes. It is important to understand and monitor your glucose levels, take your medication as prescribed, maintain balanced nutrition, stay physically active, and talk about it. A lot of people feel that when they receive a diagnosis of diabetes, that it's a terrible thing. They're scared. They want to forget about it. But experts are actually suggesting that you should talk about it. You should talk about what has been working for you, what hasn't been working for you, what are some of your fears, and maybe how can we avoid getting there? We have a lot of people, because diabetes can be genetic, a lot of people have seen their parents, their grandparents have really big complications because of diabetes. If that's a fear for you, talk about it. Talk to your provider. How can I avoid having that same experience? If you are frustrated with whatever it is, your medication management, the time it takes you to monitor your blood glucose level, talk about it. Make sure that you are talking about these things so that you can then make adjustments. Tell your provider that you're a caregiver, that as you have diabetes, you're trying to manage your condition as best as possible, but you're also talk about it is very important. Next slide, please. Now, if we are caring for someone who has diabetes, everything applies, same thing applies. We encourage them to talk to their doctor. We help them check their glucose levels regularly if they don't feel comfortable doing so. We tell them to take their medication regularly and accurately. We try to help them with their nutrition if possible, but we encourage balanced nutrition, regular exercise, and to learn more about their condition and talk about it. It can be very challenging to care for someone who has diabetes if they don't want to acknowledge that they have that condition, if they are very negative towards this condition and saying, well, I already have diabetes, there's nothing that can be done, right? We can start by offering support and not necessarily by telling them, you should do this, you should do that, but by telling them, I understand, right? I think I know how you feel. I understand, you have my support, right? So sometimes for a lot of people, when they get bombarded with you shoulds, when they're already experiencing the stress from having this diagnosis, simply a little bit of understanding and maybe even having that discussion with them of like, why is this, why are you so scared about this, right? Why are you so stressed out? Let's see what we can do. Maybe let's watch some informational videos like today's video, gathering that information before we start suggesting you should do this, you should do that, right? And again, having that appointment with the provider, that is always one of the very first steps we should be doing, because it establishes a good baseline of where their care is starting and how it can move forward. Next slide, please. And here are just some of the challenges that we can experience, right? We can have denial, indifference. If we have issues with stable housing, which a lot of the community can be experiencing, or having economic hardship, maybe there is no health insurance, maybe we don't have a budget for medications, things like that. And other complications, maybe we have other conditions like mental health conditions or other health conditions that can affect how we care for that other person or how that other person tries to care for themselves. So it could be, we can have many, many challenges. These are by no means a complete list, but they are things to consider. And again, making sure that we are discussing them and knowing that there are supports out there for us and our loved ones. Next slide, please. Now, let's talk about the relationship between diabetes and dementia. There are studies that show that if the onset of diabetes is at a younger age, there is a higher risk and incidence of some types of dementia. Now, the most common type with type 2 diabetes is Alzheimer's disease and vascular dementia. And why is this? One of the reasons is related to the effects that diabetes has on the heart, as heart health is related to brain health. And we discussed this in the previous slide. Heart disease and high blood pressure are associated with strokes, which in turn can lead to dementia. However, not everybody has a stroke, right? Not everybody who has diabetes has a stroke. So some studies have found that diabetes can lead to an increased risk of dementia, even when strokes were controlled. The reason is likely because low blood sugar levels are known to damage the hippocampus, which is the brain's memory center. One of the most intriguing hypotheses here that we have is that diabetes directly causes Alzheimer's disease. And in fact, Alzheimer's disease has even been called type 3 diabetes because of the molecular and cellular characteristics shared between diabetes and Alzheimer's. For example, this is where we have the role of insulin. Insulin plays a critical role in the formation of plaques and also in other fibrillary tangles that happen in our neurons. So basically, while insulin resistance in the body can lead to type 2 diabetes, insulin resistance in the brain can lead to the plaques and tangles associated with Alzheimer's disease. So there is still a lot of research going on around this topic or this relationship between diabetes and dementia, but it is important to note that we are finding relationships between these two. Next slide, please. Now, if we are caring for someone who has both diabetes and dementia, we are going to be facing challenges. There really is no denying that there will be challenges. However, the list that we're going to go through right now are just some things to consider. Now, of course, the main difficulty that we might be dealing with is memory loss. And of course, this will vary depending on the stage of dementia, but we will have to find ways to set reminders for that person that has diabetes and dementia and for ourselves if needed. They may start forgetting to take their medicine, check their blood glucose levels, even drink water or eat regularly. They may also not have the ability to express what they are feeling in case they are feeling hyperglycemia or hypoglycemia, right? And so they may not have the ability to express what they are feeling. They may also have, because of all these other issues, higher blood glucose levels or just uncontrolled glucose levels that can in turn worsen dementia symptoms and then increase confusion and memory loss. And of course, we can safely say that dementia can worsen diabetes management. Next slide, please. Now, when it comes to medication for diabetes and dementia, depending on the stage of dementia, we might have to contact the doctor and see if there are easier ways or different types of medication that are easier to administer. For example, for someone who has dementia and they can no longer swallow pills, we would need to find a different way of administering their medication. When it comes to feeding, we can, of course, always encourage and become informed of easy and balanced meals. However, when it comes to dementia and the very important nutritional management required for diabetes, most likely we will need to consult a dietitian to see how we can keep the meals as simple, but also as balanced as possible for this individual. And of course, it's very important to prevent accidents. And of course, dementia can cause people to become disoriented. They don't have such a good depth perception. And so this increases the risk of accidents and serious injury. Next slide, please. Now, how can we prevent? Well, we talked about controllable risk factors and uncontrollable risk factors, but we can also do other things, right? We can be physically active. We can try to maintain a healthy diet, manage our body weight, manage our blood pressure, cholesterol levels, avoid harmful habits, and find out about our family history. Do we have a predisposition for diabetes and dementia? We can always focus on prevention. Next slide, please. And for resources, we can always talk to our primary care provider. That will, for diabetes, they should always be our primary point of focus and information. We can also request an appointment with a dietitian or a nutritionist. We can look into resources that are evidence-based, like the American Diabetes Association. You can even find the availability of the DSMES program through the American Diabetes Association website, or you can also look into community connections. You can also contact 211 and they can let you know. If you call, they can let you know. Or if you go onto the website, you can also find what other community resources there are out there for you. as a caregiver with diabetes or as a caregiver for someone who has diabetes. Next slide, please. So again, just to highlight that you are not alone, there are resources, and some of these resources can be found with Southern Caregiver Resource Center. You can see here the variety of services that we offer. They are support services that are, of course, free for family caregivers. We offer family consultation, support groups, individual counseling, legal and financial consultation, education, similar to today's presentation. We have a respite and, of course, online resources. So if this is of interest to you, make sure to contact us. Next slide, please. And I also want to let you know that we have a lot of information that is available to you at any time of the day at your fingertips. And this is through our iCare portal, where you can find very short, quick tip videos in our Caregiver Corner. You can also listen to our podcast, which is called Let's Talk Caregiving, where we invite different community members or professionals in their field that have information regarding caregiving. We also have a lot of other caregiver classes similar to today's class, and you can sign up to our digital newsletter called Wavelengths, in which you can stay updated with our latest news and updates. Next slide, please. If you are active on social media, you can go ahead and scan this QR code, and you can follow us through Facebook, Instagram. You can look at our YouTube channel, LinkedIn, and even Pinterest. Next slide. And if you have any questions or if you'd like to contact us, please do so. Our website is www.caregivercenter.org, or you can call us toll free at 800-827-1008 or 858-268-4432. We'd love to hear from you. And again, if you have any other questions or if you want to see if you qualify for free supportive services, give us a call. Thank you, and see you on our next live stream. Have a good day.